In this class, we will discuss another objective personality measure used in many contexts, the Beck Depression Inventory 2. The test is used in batteries to help clarify symptom clusters, and it provides additional information that can be used in developing diagnostic impressions. The test is widely used as a screening tool administered to new clients in clinical settings, and it's widely used in research. As with other personality measures, scores on the BDI-2 are not sufficient by themselves to assign a diagnosis to a client. Rather, it provides clients with additional ways to report distress that they may not have been able to do in a clinical interview. Some of the information for this lecture on the BDI-2 was drawn from the test manual, which is cited at the end of this set of slides. The BDI and the newer version, the BDI-2, were designed to assess for symptoms of depression consistent with the criteria for depressive disorders in the DSM-4. The test has been used widely in both medical and psychiatric clinical settings, and it has also been widely used in outcome research in clinical psychology. It has only 21 items and is therefore easy to administer, and its results are easily understood by clinical teams. It is useful as a screening measure and as part of a comprehensive battery. When used in a battery, it can help confirm a DSM-4 diagnosis of depression that is hinted at in other test findings or in a clinical interview. The BDI-2 is comprised by 21 items scored from 0 to 3, and it sums to a maximum of 63. The higher the score, the greater the severity of depression. Test takers are asked to respond to the items by rating how they have been feeling in the last 2 weeks. Each item focuses on specific symptoms of depression, such as suicidal thinking, tearfulness, depressed moods, low self-esteem, social withdrawal, and vegetative symptoms such as disrupted eating and sleeping. The score options for each item uses a behavioral anchor that describes the meaning of each score as it pertains to that item. For example, on an item that asks about feelings of sadness, the anchor for a score of 0 is I do not feel sad, and the anchor for a score of 1 is I feel sad much of the time. In all cases, the higher the score, the greater the distress associated with the symptom. The test was standardized using a clinical sample and a non-clinical sample. The clinical sample consisted of outpatients drawn from a number of settings. In contrast to the large samples seen in the development of other tests we have discussed so far, the clinical sample was comprised by only 500 individuals. This sample of individuals had been diagnosed with a variety of disorders using DSM criteria. However, the sample was not stratified, and it was not representative of the national population in terms of ethnicity and gender. It was predominantly white European background, and 67% of the sample were women. The non-clinical sample consisted of 120 college students. It was also not stratified or representative of the national population. In addition, the sample was markedly younger than the clinical sample. Researchers found high internal consistency in the Beck Depression Inventory 2. They found that coefficient alpha was greater than 0.90 for both clinical and non-clinical samples. Developers of the test also reviewed the relationship of the score options for each item and how well it corresponded to the total score on the measure. They found that, as expected, higher scores on items corresponded to higher total scores. However, this pattern was not found for a few items. For example, individuals with severe depression were more likely to circle responses 0 and 1 when answering the question about suicidal ideation, rather than registering a higher score. This finding may indicate that some individuals with severe depression may actually mask suicidal thinking on the Beck Depression Inventory too. Developers of the test also found that the temporal stability of the measure in a small clinical sample was high, with test-retest reliability greater than 0.90. In terms of the convergent validity of the BDI-2, the developers of the test found that scores on the BDI-2 had very high correlations with the original BDI, with the revised Hamilton Rating Scale for depression and the Beck Hopelessness Scale. In terms of divergent validity, the developers of the test found the BDI to have strong to moderate correlations with the Beck Anxiety Inventory, the revised Hamilton Rating Scale for anxiety, and the scale for suicidal ideation. Factor analyses of the Beck Depression Inventory 2 has identified two factors. The first factor relates to somatic affective dimension of depression, while the second factor seems to relate to the cognitive dimension of depression. On the first item, or on the first factor rather, are items relating to fatigue, disruptions in sleep and appetite, tearfulness, and indecisiveness. On the second factor are items related to cognition, such as pessimism, guilt, self-criticism, and suicidal thinking. Importantly, the developers found that there was no correlation between BDI-2 scores and ethnicity. However, women have been found to score higher than men. We will continue the discussion of
Here you have an
validity
unusual problem.
in the next slide.
You should.
The developers of the test also found that scores on the BDI-2 discriminated between groups based on diagnosis. First, the mean of the clinical sample was significantly higher than the mean of the non-clinical sample. Please note that the mean of the clinical group was in the moderately depressed range, and the mean of the non-clinical group was in the minimally depressed range. Secondly, the mean of clients with diagnosed mood disorders was higher than individuals diagnosed with anxiety and other disorders. Finally, means of the most depressed individuals in the standardization sample were the highest of all diagnostic groups and at or near the severe range of depression. The total score is used to indicate the severity of the client's depressive symptoms. Test developers have also developed categorical cutoffs that can also help the clinician to understand the severity of the client's symptoms. These categories vary in their ability to correctly classify the severity of someone's depression, so the clinician, as always, should verify this classification with what he or she has learned from the client, from other test results, from the clinical interview, and from the report of others in the client's life. As shown on this slide, 0 to 13 indicates minimal or no depression. A score 14 to 19 indicates mild depression. 20 to 28 indicates moderate depression. And scores above 28 indicate severe depression. After considering the overall test score, the clinician should review critical items to explore the potential of emergent clinical issues. For example, the pessimism item, which asks about how a client feels about their future, has been found to help predict eventual suicidal behavior in clients. In addition, the item asking about suicidal thinking in the last 2 weeks should be carefully reviewed and integrated with findings from other tests in the battery, such as critical item responses on the MMPI-2. The clinician is urged to be aware that test developers found that individuals with severe depression may mask the severity of their suicidal thinking. Finally, the clinician should carefully review the items assessing vegetative symptoms. Disruptions in sleep and appetite are serious symptoms and should prompt referral for medication evaluation and a closer consideration of suicidal potential.